Today, let's learn about Hodgkin's disease, a type of lymphoma, which is a cancer of the lymphatic system. It is important to know its types, clinical features, staging and treatment, etiology and risk factors. Hodgkin's disease is of B-cell origin. By model age incidence, peak at 15, 35 years and again at 45, 75 years. Risk factors, HIV infection, Epstein-Barr virus association, pathological classification, type and prognosis. Type 1, lymphocyte predominant, very good prognosis. Type 2, nodular sclerosing, good prognosis. Type 3, mixed cellularity, prognosis is fair. Type 4, lymphocyte depleted, poor prognosis. Nodular sclerosing is most common. Clinical features, begins as painless, enlarged lymph nodes, usually cervical, may spread to mediastinal, axillary, abdominal, pelvic or inguinal nodes. Nodes are discrete, non-tender, rubbery. Alcohol-induced pain in nodes is classic. Alcohol-induced pain in lymph nodes is a classic but uncommon sign, seen mostly in cervical lymph nodes of Hodgkin's disease patients. After alcohol consumption, vasodilation occurs. Right arrow increases blood flow and causes stretching of the capsule of involved lymph nodes, where inflammatory mediators and fibrosis are present. This stretching triggers pain sensation in the affected nodes. Compression symptoms, dysphagia, dyspnea, hoarseness of voice, Horner syndrome, SVC-IVC obstruction, jaundice, paraplegia, hepatosplenomegaly, later, extranodal involvement, late feature. B symptoms, weight loss 10% in 6 months, fever 38 degrees Celsius, night sweats, HELV, Epstein fever, cyclic pattern of fever with afebrile periods, pruritus, and nephrotic syndrome can occur. Immunosuppression leads to increased risk of infections, TB, herpes zoster, CMV, candidiasis, cryptococcal infections. Clinical staging, Arbor staging. Stage 1, single lymph node region or single extralymphatic site. Stage 2, greater than or equal to 2 node regions on same side of diaphragm. Stage 3, node regions on both sides of diaphragm, with or without spleen or extralymphatic site. Stage 4, diffuse or extramural spread, liver, bone marrow. Each stage has A or B, depending on presence of B symptoms. Investigations, hemogram, normocytic normochromic anemia, leukocytosis or leukopenia, later, eosinophilia, thrombocytosis, liver enzymes, increase alkaline phosphatase, bone or liver spread. Lymph node biopsy is essential. FNA not recommended. Bone marrow biopsy, if advanced. Imaging, chest x-ray, Connecticut chest or abdomen or pelvis. Abdominal ultrasound, liver function, renal function. PET scan, very sensitive for disease extent and follow-up. Read, Sternberg RS, cells are diagnostic. Large, binucleate mirror-image nuclei. CD15+, CD30+ on immunophenotyping. Treatments, radiotherapy, megavoltage dose 3,500, 4,000 CJ over 4 weeks. Indicated for Stage 1, Stage 2, with less than or equal to 3 sites. Residual bulky lesions after chemo. Chemotherapy. Common regimens: ABVT, adriamycin, bleomycin, vinblastine, dacarbazine, MOP, mustine, oncovin, procarbazine, prednisolone. Alternating ABVD, MOPP, B-cup, bleomycin, etoposide, adriamycin, cyclophosphamide, vincristine, procarbazine, prednisone. Indications: all B symptom cases. Stage 2 with greater than 3 sites. Stage 3 and 4, usually given in cycles, 28 days, 6, 9 cycles. Cure rate greater than 75%. Combined modality: chemotherapy, followed by radiotherapy to shrunken sites. Bone marrow transplantation, autologous stem cell transplant. Right arrow successful in tilde 40% after chemo failure. Late complications: second malignancies, acute leukemia, solid cancers, cardiac fibrosis, coronary artery disease, radiotherapy related, pulmonary fibrosis, hypothyroidism. Hodgkin's disease is now highly curable with early detection and proper treatment. Keep learning, and if you found this video helpful, like, share, and subscribe at Shilpa Dias for more medical lessons. Comment below for more videos.